Nicholas. I'm a surgeon in Toronto, one of the moderators, along with Matt Premka. And it's our pleasure to welcome you to the third webinar of the year in the AHPBA Clinical Trials series. We have one additional webinar planned, likely in the winter. This webinar is focusing on a critical review of clinical trials, which we hope that you will find interesting and informative. Our last webinar was a webinar focused on trials from the trialist perspective, focusing on lessons learned and what they wish they had done differently. This webinar is similar, but with a slightly different tact. So at this webinar, we've chosen two very rigorous and high impact clinical trials that were published recently. We'll discuss those shortly. But we've asked two members of our clinical trials committee at the AHPBA to critically review them and really to put the senior investigators for each of the trials on the spot with some pointed, difficult questions for them. So we will be moving through the two trials. We will present a critical appraisal of them, and we're really very pleased and honored to have the two senior investigators here, and we'll introduce the panel shortly. I would ask that if you have questions, please use the chat function and we will moderate that. We will try to have some time for discussion at each of the presentations and perhaps some overall discussion at the end as well. So with that, I'm going to turn it over to Dr. Premka to introduce our panelists.
Excellent. And so welcome everyone to this Clinical Trials Committee webinar. The first, we'll go through and have our introductions of our panel. I'm Matt Premka from the University of Southwestern in Dallas. We also have our two clinical trial members who will be presenting the studies today. One is Jonathan Sham, and the other is Catherine Davis. Our senior attendings are Sai Ahmed and Michael D'Angelica. We'll be leading off with the S1505 study, which is a efficacy of perioperative chemotherapy for resectable pancreatic adenocarcinoma. Presenting this will be Jonathan Sham. He is an assistant professor of surgery at the University of Washington and the Fred Hutchinson Cancer Center. He received his medical degree at the University of Pennsylvania and surgical training at the University of Washington. He completed fellowships in both complex general surgical oncology and HPB surgery at the Johns Hopkins Hospital, where he also obtained a master's in biotechnology enterprise. He's active in clinical trial development through the AHPBA and SWOG. He chairs the S2408 randomized multicenter phase 3 trial evaluating lanreotide for the prevention of postoperative pancreatic fistula. Today, he will be presenting S1505, and he will be kind of quizzing and challenging the PI, who's Sai Ahmed. He is the co-director of the University of Cincinnati Cancer Center, the Hayden Family Endowed Chair for Cancer Research, and the Professor of Surgery for the Division of Surgical Oncology Chief. He was really responsible for all of the cancer-related academic and research outputs at the University of Cincinnati. He's nationally recognized. He's published over 200 articles, and we're really happy that he'll be able to help us out today. So with that, Jonathan, I'll turn it over to you.
Thanks so much, Matt. Just want to make sure you can see my slides okay. Perfect. Well, thanks all. Hello, everyone. And thanks, Dr. Ahmad, for joining us for this, I think, what's going to be a really exciting webinar. I have the pleasure of presenting SWOG 1505, which evaluated the efficacy of perioperative chemotherapy for resectable pancreas cancer. To put things into perspective, in 2015, when this rolled out, there really were, similar now, a lot of questions about operative regimens for perioperative chemotherapy and operative timing for chemotherapy, neoadjuvant versus adjuvant. And this study looked at overall survival using two common perioperative regimens, which we'll get into shortly. So big picture study design is a randomized phase 2 clinical trial of patients with biopsy-proven pancreas cancer, which was resectable. Patients were stratified based on the performance status and randomized 1-to-1 to receive either perioperative FOLFIRINOX or gemcitabine Abraxane. As long as they didn't progress on the preoperative regimen, they went to resection. I'll show you here the schema. I think this is kind of easy for people to see. It's fairly straightforward, which the NCTN likes. So randomization, you either get FOLFIRINOX or gemabraxane, half before, half after, restaging, and then again, as long as there's no progression, you go on to surgery. Now, I think it's important to point out the statistics here. You know, as surgeons, I know a lot of times we kind of our eyes gloss over here, but this was really a unique design now, and even at the time. This was so-called pick the winner phase 2 design. And for those of you who are not familiar with it, it's not a head-to-head comparison. We're not comparing gemabraxane with FOLFIRINOX. What they do is we compare each regimen against a historical control. That's the so-called null hypothesis. And that was set at 40% 2-year overall survival. And essentially, if it hits up to 58%, either one is seen to be positive, to show difference. Anything below that, again, does not refute the null hypothesis. The goal accrual was 100 patients with about a 10% bump for dropout. Here's a big picture of the study timeline. I think it's really helpful to understand kind of how this played out over a 5-year span. So it opened in 2015 in October, and in 13 months enrolled 76 patients, really just blazing fast for a multi-center clinical trial. In November 2016, it was paused for a planned interim analysis. I'll say, and Dr. Mott will probably comment on this later, but kind of surprisingly, was found to have a 33% ineligibility rate. And that was essentially patients who did not meet the inclusion criteria after retrospective review. So because of this, some kind of real world fixes were implemented, including an institutional radiology checklist, and the sample size was increased to 150 to account for these inevaluable patients. It reopened to accrual just a few months later in January, and then a year and a bit later in April 2018 completed accrual. And then, of course, given 2-year survival was the primary outcome, was presented at ASCO 2020, 2 years later. Here's a peek of this consort flow diagram. You can see that 146 patients were reviewed by central radiology, and 29% overall were deemed to be ineligible. And this was kind of very similar in both arms of the trial, 19 versus 25. When you look at why they were found to be ineligible, interestingly, it looks like arterial abutment and suspicion of metastatic disease were the primary reasons. You can see 51 and 65%. Respectively. Now, you'll know that if you add all these numbers up, it's more than 43. That's because actually a lot of patients had more than one of these that were found by central radiology review. So it's important to point that out. Now, for those of you, particularly trainees who might be looking at these consort flow diagrams for the first time, I would always get confused when you talk about percentages. Are you talking about the overall population, you know, like eligible, what? So what I've done is I've circled the denominator for any percentages I've given here to help you kind of see the numbers more clearly. And so for those who were found to be eligible, 84% completed preoperative chemotherapy in the FOLFIRINOX arm, 85% in the gemabraxane arm, so very similar. And then 73% and 70% underwent resection. You can see that when we look at some of the reasons why people didn't undergo resection, some of the adverse events, neutropenia was a big one for gemabraxane over FOLFIRINOX, and FOLFIRINOX had a slightly higher rate of diarrhea. Now, when you look at post-resection, you can see that for those who underwent resection, 40 in the FOLFIRINOX arm, 33 in the gemcitabine arm, almost 80% in each arm actually started pre-op chemotherapy, and then 68% finished post-op, and 58% in the gemabraxane arm. Now, if you look at all comers, so if you're looking at a patient, a new diagnosis of pancreas cancer in your clinic, and you want to predict, well, what's likely they're going to get through everything, pre-op, resection, complete post-op, it's actually just about a coin flip. It's about 49% full FOLFIRINOX and a little bit less than gemabraxane. So just kind of important perspective to keep in mind to understand a lot can happen between seeing that patient the first time and getting them to kind of the end of planned therapy. When we look at our primary outcome, which is 2-year overall survival, neither arm was statistically higher than the null hypothesis. So FOLFIRINOX and gemabraxane, 47 and 48% respectively, with a median overall survival of about 23 months for each. And you can see kind of the overlapping Kaplan-Meier curves here. Some other interesting outcomes just to know: R0 resection, about 85% each, similar nodal N0 status. But I think kind of unexpectedly, a higher major and complete pathologic response rate in the Abraxane arm compared to FOLFIRINOX. I think that'll be discussed later, and kind of how that information is used to inform future clinical trials. So what did we learn? Well, running a trial in the NCTN evaluating perioperative chemo is feasible. I think that actually was a question, and we even hear now, well, can you accrue to a surgical trial in the NCTN? And the answer is yes, and it can accrue rapidly. But it did really bring up important questions of quality control, given the really high ineligibility rate found at that interim safety review, and we can talk about that. And I think this really highlights how important, not just the utility, but the critical nature of central radiology review in these trials. There was no improvement in overall survival compared to historical adjuvant studies. I think that's an important note. And this really does establish kind of these benchmarks for the efficacy of FOLFIRINOX and Abraxane for future trials as well. And of course, we always want to think about the next study. This does provide a platform for future trials, and maybe Dr. Ahmad will talk to us a bit about 2411, which is coming down the chute very quickly. So that's what I have as far as the presentation. Matt, I'm happy to get straight into questions if you like, or is that the way we want to go now?
Yeah, I think now we can just proceed to some questions and really just encouraging the audience. If you guys have any questions, put them in the chat and we'll make sure we address them.
Perfect. Well, Dr. Ahmad, again, thanks so much for joining us. Really appreciate it. I wonder, just to start off, if you can take us back to November 2016, you have that interim review. What was the emotion when you got that data? Like, was it surprise, frustration? Can you take us down to the study team maybe and talk about some of those discussions and how you decided to move forward from that data?
Yeah, so first of all, I want to thank
sorry, just Jonathan, can you maybe stop sharing? Oh, perfect. Thank you. Sorry to interrupt. Go ahead.
Yep. So I just want to thank the committee and the AHPBA for inviting us to discuss this paper. Certainly honored to be included. Again, I want to congratulate you on putting together these seminars that are so popular and educational. So, 1505, when we first designed this study, it's all based on what's available to you. So at that time, we did not, within the SWOG infrastructure, have a radiology core. Since that time, there's now an established radiology core that supports all the cooperative groups through the NCI, IROC. Actually, the person that runs it, I've subsequently recruited to Cincinnati. So I wish, he was here at that time. That's Michael Knopp. But at that time, we did not have access to real-time radiology review. Now, I conducted this study on the heels of working with Matt Katz in the Alliance on the two borderline resectable studies, 0211 and 0215. And those studies had real-time radiology reviews. When we started this, we started with the assumption that these are resectable patients. It's going to be straightforward. People will know what resectable is, and we probably can get away with not having real-time radiology review. But we did build in an interim analysis to make sure that assumption was correct. And so when we had that interim analysis, we were frankly surprised that there are so many people being enrolled based on retrospective review of imaging that were really not candidates for the surgery. And most of the people enrolled were really borderline resectable patients and those that had suspicion of metastatic disease outside the nodal basin. So in large nodes, outside the peripancreatic region, level 2 nodes that hadn't been biopsied or sampled. And so, we went back at that time and we instituted several things. We, number one, had inclusion criteria that were outlined, but we didn't mandate a checklist. So, if you run studies through the cooperative group, one of the things that you can do to ensure compliance is develop these checklists that the CRAs have to fill out before the patient gets enrolled. So we developed the checklist, and then we started having monthly phone calls with the investigators around the country for them to ask questions about eligibility and things like that. And once we instituted this checklist and had those monthly phone calls, enrollment became a little bit cleaner, so to speak. There were still, patients that got enrolled that we would follow in real time and go back and, query the institution about eligibility. But it was a lesson learned how quality control is so important in surgical trials. No matter, you can't make assumptions. And that was one of the things that we learned here was that, everything has to be very stringent with regards to eligibility and quality control. So now, multiple studies that have been designed subsequent to 1505 have incorporated real-time review. And again, it's really based on what was feasible in terms of getting the study off the ground, getting it going versus what was available to us. At the time of the genesis of the study, we just didn't have real-time review available. We do now have it. So the subsequent study that we're working on, 2411, does have that built in.
That's super helpful. And maybe along those lines, I, as you know, work through SWOG to try and get trials through. And everything I hear from every level of the approval process is feasibility, feasibility, feasibility. Mm-hmm. So can you tell us, you were able to enroll 76 patients over 13 months.
It's a great question. Again, this is another lesson of sometimes you just got to be lucky. Again, rewind the clock back, and I alluded to the fact that, that I worked with Matt on the 2 borderline resectable studies. To give you an idea, like the very first study we did, the Alliance 0211, that was really a 5-year process from idea to actually getting the study open took 5 years. This, on the other hand, was lightning quick. And the reason was there was nothing else in the pipeline. When you design a study, and through the cooperative group, you're really looking at what do the other cooperative groups have? What's going to compete against this? There were just no good ideas out there. And when we proposed this idea, everyone just jumped on it. Like all the other cooperative groups, like, yes, we'll support this. The GI steering committee, CTAP, boom, boom, boom. It just got through really quickly. So when it was open, there were no other competing studies on a national level. And so people were just enrolling on the study because, there were just nothing else to enroll patients onto. So again, it's a lesson, and sometimes you just got to be lucky and be at the right time, right place at the right time. And this was reflective of that.
That's super helpful perspective. So, I mean, as the cooperative groups are kind of an iterative process in designing these, did you have to make any concessions during the approval process? Is 1505 different than what you submitted, at the beginning of whatever it was, 2014?
Again, the answer is pretty much what we proposed is pretty much what we got. We didn't have to make concessions, although again, that's very, very rare. Seeing a few of the investigators on here who have some, experience in trying to get studies to the cooperative group will tell you that, it's a lesson in having patience and biting your tongue and just, doing what you need to get the ball across the finish line. And then again, in this particular case, we didn't have to make a lot of concessions. We proposed a study that really had minor changes, but the schema that Jonathan showed was pretty much a schema that we proposed.
That's outstanding. Maybe you can give some perspective for those who aren't as familiar with the stats. Why did you choose pick the winner design for this? And, what are some of the advantages and disadvantages?
Yeah, so pick the winner design was originally introduced to study novel drugs in a rapid fashion. It is what we call an adaptive clinical trial design. And the process of pick the winner is really, you have multiple stages of evaluation. And at each stage, you can close a study rapidly. So you don't waste patients going forward. In a stringent traditional clinical trial design, once you open the study, you've got to complete the study. In an adaptive trial design, you have the flexibility to open and close arms quickly based on signals. The other reason is, when you think about this, this is a perioperative platform that we're proposing, and there are really no good historical control. There hadn't been any studies that had looked at a perioperative platform that we could use as a benchmark, as a historical control to compare these arms to. So in a traditional pick the winner design, you would have a standard arm that's considered the historical control that the other arms are being compared to. in this particular study, because both were novel arms, we're comparing them to historical controls, not to one another. Does that make sense?
For sure.
And we built in an interim analysis to find a signal, and that we're looking at comparing each arm to the historical control of 40%, but the null hypothesis was really 58% to your overall survival. But the one thing I want to correct you in your presentation was you said that neither beat historical control, but both arms actually beat historical control. If you go back to your survivor curves, you'll see that the 2-year overall survival for each arm was actually better than historical control. But because it didn't reach the null hypothesis, we couldn't compare the two arms to one another. So they're really independent analysis to historical controls. So the conclusion really, as you alluded to, is that it established both arms as a reasonable option to manage patients with resectable cancer, because there was a signal relative to historical control. The other thing I'll kind of point out is that the study came on the heels of 2 adjuvant studies, the Prestige study that found FOLFIRINOX to be impactful in the adjuvant setting, but also the APAC study that didn't find gem-paclitaxel to have a signal in the adjuvant setting. So this study kind of reinvigorated gem-paclitaxel for resectable patients, because prior to the study, no one was using gem-paclitaxel for resectable patients. At least there was no evidence. But now in a perioperative platform, this study demonstrated that not only is there a signal in the perioperative platform, but maybe it's the same as FOLFIRINOX. Again, you have to be careful comparing head to head, but there was certainly a signal for both, equivalent signal for both relative to historical control.
So I know certainly the study wasn't set up to look at this question, but does the really high north of 80% completion rate of neoadjuvant chemotherapy, does that support the practice of total neoadjuvant therapy? And did your practice change?
So I was actually just in India last week at the AHPBA conference, and I was debating, I was asked to debate neoadjuvant versus adjuvant. And that was one of the big messages that was part of my debate, was the complete ability to complete therapy. It's not only, if you look at the preoperative regimen, about 80% people completed preoperative regimen. And in the back end, the adjuvant side, less than 50% completed the regimen. And we know that completion of chemotherapy is paramount in terms of improving survival. So this is really good evidence that maybe we should be looking at total neoadjuvant therapy, because it's very hard to give it after therapy. And in fact, you alluded to our next study, which is SWOG 2411, which will be a 3-arm study looking at FOLFIRINOX total neoadjuvant. Second arm will be FOLFIRINOX plus an IL-1 RAP inhibitor. And the third arm will be FOLFIRINOX plus a CXCR4 inhibitor and a checkpoint inhibitor, based on some preliminary work being done in Dr. Venu Pellersetti's lab at University of Washington. He's also a co-PI on the 2411. And so that study is looking at total 6 months of neoadjuvant therapy prior to surgery. And there'll be a lot of lessons to be learned in there. One of the things that we did point out is that neoadjuvant therapy is not free. Yes, more people get it, but there were a subset of patients who didn't get to surgery because of the toxicity of the chemotherapy. And so if you look at that number, it's single digits, but it's really important to understand who those patients are, because maybe in those patients we need to adjust the chemotherapy or maybe consider a different sequencing regimen. So the thing to understand is that yes, more people get chemotherapy pre in the neoadjuvant fashion, but there are some people who actually don't get to surgery because of the side effects of the chemotherapy. And so we need to not forget that. Now, the other thing that you did present today, and we'll be hopefully submitting an abstract to SSO, is looking at dose density. So dose density is a newer concept on how much chemotherapy you got relative to what was assigned. So people talk about how many months of chemotherapy you get, but you could get 3 months of chemotherapy, but you've missed cycles, you have reduced dosages a cycle. And so, the total amount of chemotherapy you get maybe 3 months, but really at a reduced amount. So if you look at this concept of dose density, well, we've done analysis, a landmark analysis in 1505 study, and demonstrated that, again, the dose density in the preoperative sequencing was much greater than in the adjuvant setting. So the dose density in the pre-op was about over 80%, and the adjuvant was less than 70%. So not only are you getting less chemotherapy in terms of months, but you're also getting a reduced amount, missing cycles. And so all that kind of, is associated with survival. And so not only how many months of chemo, but the dose density of chemo is just as important.
That's super interesting. So were you surprised to see the increased pathologic response rates when Gemabraxane? And I guess if that's real, why was FOLFIRINOX chosen for 2411?
Yeah. So again, we can't compare those pathologic response rates to one another. It was a pick the winner design, so you can't compare head to head. So you don't know if that's a statistically significant difference. What it tells us is that it's at least as good as FOLFIRINOX. The reason FOLFIRINOX was picked for the 2411 is because that's the national standard. People are, again, you talked about feasibility. So if you do a study and you have Gemabraxane as a backbone and the national standards FOLFIRINOX, people aren't going to roll to the study. So you have to pick a design where people will say, yes, this is, going to give what I normally give plus maybe something else. And so again, you even though Gemabraxane is appears to be equivalent, we don't know for sure, to FOLFIRINOX, and maybe the pathologic response rate is a little bit better. There's some signals there that are interesting that needs to be further investigated. Feasibility of completing a study is really based upon what the national practice patterns are, and the national practice pattern is really FOLFIRINOX. So if we chose something different, it may have had a hard time accruing patients.
I think that's super important. It's kind of like tie goes to the runner, but tie goes to what medical oncologists will prescribe, what they're already prescribing. It's huge importance, more for feasibility. I might have one more question, and then maybe go to the chat. What is most misunderstood about this trial? Well, obviously a lot of people know, they kind of quote 1505. I've heard people come to varying different conclusions about it, but what's most misunderstood, and other than central radiology review, what would you
say? That's a really important question. So the first thing I want to point out is that people look at the results in terms of median overall survival, and I don't remember the numbers off the top of my head. It's around 22, 23 months for each arm. And then compare it to the median overall survival for like the adjuvant PREDIGE study, which is, really in the 50-month range. The thing to understand is that this is a real world trial. The patients are enrolled upfront, all comers. And the results you get are reflective of real world patients. Whereas a PREDIGE study, which is an adjuvant setting, it's highly selected group of patients. Number one, you did surgery. So people who had metastatic disease found at surgery were excluded. Number two, people recovered from surgery, so the performance status is good. You had a repeat CT scan, so you've excluded early progressors. And then you enroll patients based on a CA19-9 level. So the numbers that you get in the PREDIGE study are reflective of a very highly selected group of patients. One way to kind of look at that is if you look at the GEM arm in the PREDIGE study, the median survival in the GEM arm was over 30 months. And so if you go back and look at SPAC1, SPAC3, SPAC4, CONCO, the median survival for the GEM arm in those studies were in the range of 20 to 22 months. And so again, why was the GEM arm in the PREDIGE study so high? And the reason is, again, this was a highly selected group of patients. So the GEM arm tells you how selected these groups were. And so the thing to understand about this study is that this is real world, that, these are the patients we take care of. No one's been excluded. Everyone's been included because everyone's enrolled and randomized up front. And this is also a platform for future progress. And I think the future progress really is looking at not just chemotherapy, but using novel biologic, targets, manipulation of the tumor microenvironment, and adding to chemotherapy. I mean, chemotherapy we have is improved from what it was 20 years ago, but we have a long ways to go. I think the next phase in progress is going to be understanding biology, manipulating the tumor environment, making a tumor that is not amenable to immune therapy, amenable to like CXCR4 inhibition, and kind of combining, novel approaches. also, understanding that what's most important for these patients is delivery of chemotherapy. That's what's going to make them live longer. And the best approach for that is a neoadjuvant, total neoadjuvant platform.
I think the real world nature of the data that you mentioned just can't be understated. And when patients ask me about survival, they want numbers, like those are the numbers I give, or 1505, because it's the best we have, really. Paul or Matt, did you guys want to go to the chat?
Sure, yeah. So thanks so much, both of you. That was a phenomenal discussion. There are a couple of questions in the chat, and I have a question or two as well. But maybe I'll go to the chat first, Dr. Ahmed. The first question here asks about whether the results of this have changed your approach to borderline resectable patients at all, based on the apparent differing rates of major response with the two regimens. I know you commented a little bit about difficulties comparing them. Can you maybe expand on that?
Yeah. So, so the way we handle both resectable and borderline at my institution, University of Cincinnati, is we try to get as much chemotherapy in as possible upfront. And so typically the average patient will get 4 months of chemo, then surgery, and then, whatever we can give on the back end, hopefully two additional months. We still favor FOLFIRINOX. And again, I want to emphasize that even though the path response rate was greater than Gem/Abraxane, you can't compare it head to head to FOLFIRINOX. Pick the winner to historical controls, not necessarily against one another. So again, what we can conclude is that Gem/Abraxane potentially delivers the same response rate as FOLFIRINOX. Prior to the study, there was a bias that FOLFIRINOX was far superior in terms of response rate to Gem/Abraxane. Based on the study, we can say that it's probably not far superior. It's probably equivalent, but we can't say Gem/Abraxane is better. So we continue to use FOLFIRINOX, again, based on practice patterns here. The other thing that we're starting to do now is we're looking at response, both based on CT and biochemical response. And if someone's not responding, we are very low. We have a low threshold of switching regimens. So if we give several months of FOLFIRINOX and the CA19-9 hasn't gone down, there's no RECIST response, that typically we'll see about 20% of the time in pancreas cancer, then we'll switch to the Gem/Abraxane, because we know, that we want to maximize response prior to doing surgery, so that whatever chemo we give on the back end, we know it's going to be effective.
Great. We have another question in the chat, appreciating your insights on real-world results, and asking whether or not you were surprised at the low number of patients who made it to resection in this trial.
The numbers are consistent with what we knew, and one of the advantages of neoadjuvant therapy are progressors. And most of the people who didn't make it to surgery are people who progressed on therapy. And just to remind everyone, the formation of metastasis probably is a multi-year process. And so if someone progresses on neoadjuvant therapy, those aren't people that failed. Those are people you spared unnecessary surgery. And so that's actually a good thing. So people who progress and did not get to surgery, are getting what they need, which is chemotherapy. And, if you took those same patients and did surgery first, those are the same patients where you'd have metastasis on the CT scan at 3 or 6 months. And those are the same patients who really didn't benefit from the surgery. So most of the people who didn't make it to surgery were based on biologic progression, systemic progression, not local regional progression.
Okay, and I have a question here. So both this trial and the subsequent 2411 are sort of making the assumption that neoadjuvant therapy is the way to go and putting all our eggs into that basket. I wonder philosophically how you feel with that in context with NORPACT-1 and the results of that. And then for the practical question, with Alliance still out there, what would be your plans with 2411 if Alliance reads out whenever it does, similar to NORPACT-1, and in fact neoadjuvant chemotherapy is actually, it seems to be harmful? So
the question you're asking is, does sequencing make a difference? Does sequencing make a difference like it does in rectal cancer? Does sequencing make a difference like it does in esophageal cancer? Or is there secondary benefit to neoadjuvant therapy? And I think the answer is there's secondary benefit, because pancreas cancer is one of these cancers. So when you look at the NORPAC-1, you look at the current Alliance 0218 that Christina Ferroni is running, and even the PREAPANC-3 study, which is pretty much the same as the Alliance 0218 that's ongoing, that our colleagues in the Netherlands are doing. Alliance 0218 and PREAPANC-3 are the two ones that are out there that everyone should keep track of. The reason those studies probably won't show a difference, maybe, hopefully I'm wrong, but probably won't show a difference because we're doing intent to treat analysis. And when you do intent to treat analysis, the early failures that we expect, 20 to 30%, will be included in the analysis. So if you look at neoadjuvant arm, 20% of people won't get to surgery, but they'll still be included in the survival analysis. And so that will negate the benefit of the neoadjuvant sequencing. That's not true in rectal cancer, esophageal cancer. You don't get those failures that negate the benefit. And so, the way you have to look at the benefit is looking at things like dose density, completion of chemotherapy, looking at secondary endpoints like people getting therapy that was appropriate. In other words, not getting unnecessary surgery. Like in the surgery first arm, there'll be 20% of people who got unnecessary surgery, whereas you won't have that in the neoadjuvant arm. You have more people completing chemotherapy in the neoadjuvant arm than you will in the adjuvant arm. So the benefit of neoadjuvant may be hard to find in head-to-head comparison because you're doing intent to treat, but the benefit really is in these secondary gains, completion of therapy, testing biology, and other things like margin negative rates, node negative rates, things like that.
Great. There's a couple more in the chat. I think we probably have time for another couple here. Can you go into more detail about the ineligible patients coming to this trial and how the checklist helped? Why were patients who were not eligible going through the screening process?
So the definition we used for resectable and borderline resectable was the intergroup definition that was developed in the context of the 0211 and 0215 study, the borderline resectable. So, Matt and I developed those definitions based on the previous MD Anderson definitions that Gary Vettachari had developed. And, it was a new definition. It's now been incorporated into the NCCN guidelines. But it was basically in the heels when people were kind of understanding the difference between resectable and borderline resectable. And so remember, this study is open not only at high volume centers, but also at community hospitals and other low volume centers through the community oncology programs. And so not everyone may have the nuanced sophistication of understanding resectable and borderline. And so there were a lot of people who were borderline resectable that were enrolled. And the checklist really made it kind of something that they went step by step with the radiologist, like, is there 180-degree involvement? Is there any arterial abutment, et cetera, et cetera? And that kind of really helped teach people the difference between resectable and borderline.
And I think last question for now relates to biomarkers here. So there's some evidence that certain pancreatic cancers have differential response to chemotypes based on molecular characteristics, and this is referencing basal versus classical types here, and asks a question about whether there's risk for progression and potentially causing harm, I suppose, by missing the surgery window if they are in a subtype of patients that are not responsive to chemotherapy.
So there's a couple questions mixed into that. So the first is the transcriptomic subclassification that was, there are multiple, the one that most people use, the one that Zhenjian Ye came up with at UNC. There's also one by Eric Collison. But the Zhenjian Ye classification is the basal and classical, and there's some evidence based on data from David Linehan's lab at the University of Rochester that classical subtypes tend to respond to FOLFIRINOX and basal tend to respond to Gem-Abraxane. Interestingly enough, Susan Tsai and Zhenjian Ye are looking at the 1505 tumor repository to see whether we could determine transcriptomic signaling and then whether or not that was able to predict which ones they responded to. So we don't have that data yet. They're working on it, but we are looking at transcriptomic profiling in the 1505 database. The second question is missing the window of opportunity to operate. And I want to specifically address this because this is another thing that people argue against neoadjuvant therapy, that if you do neoadjuvant therapy, you'll miss the window to operate. So remember, most progressions that occur during neoadjuvant therapy are distant progressions. Distant progression, systemic failure is a result of something that started 2-3 years before the patient met the doctor. So if someone has systemic failure, that's not missing the window to operate. That's actually a good thing for the patient. They're not getting unnecessary surgery. That would have happened whether you did surgery first or neoadjuvant first. So when you talk about window of opportunity, you're talking about local regional progression. So if you look at series, there are 3 or 4 series that have looked at this. The risk of local regional progression going from resectable to borderline or resectable to locally advanced is about 1 or 2%. And if you look at those series, even the people who have local regional progression underwent successful margin negative resection. So local progression on neoadjuvant therapy typically does not preclude you from undergoing successful surgery. And local progression is extraordinarily rare. So neoadjuvant therapy does not lead to a loss of window of opportunity to operate.
Wonderful. So thanks so much for all of that. I think we'll move on with that to the second trial.
Thanks, everyone.
So now we'll be switching gears to the NSQIP antibiotic trial, and to present the trial details is Catherine Davis. She attended medical school at Tulane University and then completed her general surgery residency at Houston Methodist Hospital, followed up by a research fellowship and MPH at MD Anderson. She then went and got her complex general surgical oncology fellowship at Rutgers in New Jersey. And now she's a surgical oncologist at Baylor Scott & White in Dallas. And she focuses on HPV malignancies and serves on our clinical trials committee here at the AHPBA. She's paired with Dr. D'Angelica, who many people know here well. He is an attending at the Memorial Sloan Kettering Hospital. He is the Enid Hop Chair in Surgery, Vice Chair of Education, Director of the HPV Fellowship, and the Director of the Surgical Oncology Fellowship. He has numerous publications, led a whole bunch of trials, and also serves in multiple leadership roles in the AHPBA and related societies. So thank you both so much for presenting, and we look forward to learning from you. Catherine.
Great. Thank you very much to the AHPBA for the opportunity to review this very impressive trial, and for Dr. D'Angelica for being here. Are you seeing slides okay here?
Yep.
Yep, great. Okay, so we'll be discussing Dr. D'Angelica and colleagues' clinical trial published in April of this year, published in JAMA, piperacillin tazobactam compared with cefoxitin as antimicrobial prophylaxis for pancreatoduodenectomy. All right, so surgical site infection is a major source of perioperative morbidity following pancreatoduodenectomy. Contributing factors to SSI following pancreatoduodenectomy are complex, and improving SSI rates has been challenging. Published guidelines recommend first or second generation cephalosporins for surgical prophylaxis, which have limited coverage of resistant pathogens. However, limited retrospective studies suggest improvement in SSI with broader prophylactic antibiotic coverage. And with that in mind, the aim of this study was to determine whether the use of broad spectrum antibiotic prophylaxis improves postoperative SSI rates following pancreatoduodenectomy. So this trial was designed by the American College of Surgeons Division of Research in Optimal Patient Care and the AHPBA Clinical Trials Subcommittee. This was a multi-center open label phase 3 randomized trial. And very importantly, this was the first trial in North America to be registry linked using the American College of Surgeons NSQIP pancreatectomy procedure targeted program. And very briefly, I want to stop and describe NSQIP for those who aren't as familiar. This is a program by the American College of Surgeons that is a validated prospective multi-institutional outcomes and quality program. It is routinely audited and uses trained nurse reviewers to collect data on more than 150 demographic and perioperative variables. And the pancreatectomy procedure targeted program is an augmented program that includes additional perioperative variables pertinent to patients undergoing pancreatectomy. The patient population consisted of patients undergoing open pancreatoduodenectomy for any indication, and patients were excluded if they were unable to receive either antibiotic in the trial, were chronic systemic corticosteroid users, had preoperative antibiotic use within 7 days, known preoperative infection including intra-abdominal abscess or cholangitis, were dialysis patients or who had low creatinine clearance, were pregnant, or breastfeeding. And the goal with these criteria was to increase generalizability of the trial findings. So here we see the concert flow diagram for the study. 967 patients were randomized in a one-to-one fashion, stratified by presence or absence of biliary stent, and randomization occurred centrally at Memorial Sloan Kettering, which was the leading center of the trial.
Sorry, Catherine. Sorry about just for this slide. You're in presenter mode. I wonder if you can. Sorry about that.
No problem.
Sorry to interrupt.
Thank you for letting me know. Is this better?
Perfect. Yeah, that's perfect. Thanks.
Yes. So after exclusions for unresectability, surgery cancellations, preoperative disease progression, consent withdrawal, or preoperative infection, 778 total patients were included in the primary analysis, 378 in the intervention arm with broad spectrum antibiotics, and 400 in the standard of care arm with cefoxitin. The intervention patients were randomized to cefoxitin or piperacillin tazobactam within 60 minutes of incision and redosed every 2 to 4 hours until close of incision, and antibiotics were stopped within 24 hours after close of incision. Participants who did not receive the correct antibiotic, had inappropriate intraoperative dosing, or had prolonged antibiotics beyond 24 hours postoperatively were marked as protocol violates, but they were still included in the primary analysis. And primary outcomes in the study included superficial, deep, and organ-space SSI, and patients who died or were followed or lost to follow-up within 30 days were considered events toward the primary endpoint. There were many secondary outcomes that were postoperative outcomes, often seen downstream of perioperative SSI. Subgroup analyses were performed by sex, BMI, use of preoperative biliary stent, receipt of neoadjuvant therapy, pancreas gland texture, duct size, use of wound protectors, and perioperative blood loss. Sample size calculations were based on an overall SSI rate of 20.4% with a 40% reduction in SSI to 13% being deemed a clinically meaningful endpoint for the study. And all analyses were performed on a modified intention to treat basis, regardless of dosing violations, though patients were admitted or were omitted after randomization if they were deemed unresectable at the time of surgery. So between 2017 and 2021, again, 967 participants enrolled and were randomized by 86 surgeons at 26 institutions. 20% of patients were excluded after withdrawing consent or for not undergoing pancreatoduodenectomy, for a total of 778 patients. 58% had preoperative biliary stents, 35% had neoadjuvant therapy, and 63% had pancreatic ductal adenocarcinoma. And here we see our table 1 looking at demographics, which are fairly evenly matched groups as a result of the randomization process. The only thing to note here is that perhaps the intervention arm, Zosyn, had more hard glands and less soft glands than the cefoxitin group. So when we look at primary outcomes, patients who received piperacillin tazobactam had statistically significantly fewer SSIs than those who received standard care cefoxitin, 19.8% versus 32.8%, with an odds ratio of 0.51 for patients receiving broad spectrum antibiotics. And the difference in groups was consistent when subdivided into superficial SSI and organ space SSI, but not for deep incisional SSI. So we see odds ratio of 0.34 in the superficial SSI group and 0.57 in the organ space SSI group for those receiving Zosyn. As for secondary outcomes, patients receiving broad spectrum antibiotics had statistically significantly lower odds of having postoperative pancreatic fistula with an odds ratio of 0.62%, sepsis with an odds ratio of 0.55%, and C. diff colitis with an odds ratio of 0.07. And this is a large figure for the slide, but just represents the subgroup analyses that were performed, and we see in most subgroups broad spectrum antibiotics is favored. Limitations as stated in the discussion section of the manuscript include that there was a higher than expected rate of unresectability or disease progression leading to post-randomization exclusion, 20% versus an expected 10%. There were no routine collection of intraoperative or postoperative culture data due to trial design and lack of funding. However, this was addressed in a follow-up study. And there were a slightly higher number of protocol violations in patients receiving piperacillin and tazobactam. And finally, this was an unblinded study. So in summary, perioperative use of piperacillin and tazobactam as an antimicrobial prophylaxis reduced the risk of postoperative SSI, pancreatic fistula, and multiple downstream sequelae of surgical infection compared to standard care cefoxitin in patients undergoing pancreatoduodenectomy. And also separately and importantly, this was the first registry-based trial in North America, which has significant implications for accrual and cost, and may be important future in the future, particularly for conducting these very notoriously difficult to perform surgical trials. So that is the end of this presentation. And then I have a few questions prepared for Dr. D'Angelica. So one of the most interesting aspects about this trial design to me is pioneering using the NSQIP platform to run a randomized clinical trial. And this is a novel and seemingly more practical way to run a multi-center surgical trial. But as we know, there are inherent limitations associated with NSQIP. Can you discuss this a bit further?
Sure. Thanks, Catherine, and thanks everybody for the invitation. It's definitely an honor to be here. Yeah, there are of course limitations in it. The most obvious ones before we get to the ones that may really impact conclusions are that you can only study what they collect, right? You can't say, oh, well, I want to study a bunch of other things. It really has to adopt to the platform, and it's only 30-day outcomes, and it's only specific things that they have defined themselves, and so you can't go in and change definitions. You are limited to that. Having said that, it's a well-defined, very reasonable assessment of perioperative morbidity. Also, from the practicality of what institution could be involved, is you have to be involved in a collaborative that studies the specific operation you're discussing, and you have to be collecting all data on all cases at your institution. So if you look at general surgery NSQIP, they generally do a 10% random sampling. You couldn't do a trial on that because you might randomize someone and then they decide not to collect the data on that. So all of these institutions had to invest in the collaborative and be involved in collecting all NSQIP data on all pancreatectomies. And so that was a necessary thing. It does limit the institutions that can be done. The other obvious limitation is you can't control for everything. This is the term we used a million times over and over. It's pragmatic, right? And Dr. Ahmad said the same thing about his trial, real world. And I think this is a more extreme example of real world. We're not going to control every little thing, although we had data on a lot of things. And I can tell you a lot of the big journals were very uncomfortable with that idea, although there are many examples of these kinds of pragmatic trials out there. And I think if you got two people, you could have a debate whether that's a good thing or a bad thing. I can tell you my own hospital, we have done single institution, highly controlled trials that have not impacted practice one bit or very little. And I think actually this platform probably has the ability to impact more people because it's more believable and more people have invested in the question. But that's up for debate. It's a little different than a cancer trial, a little different than other kinds of trials. So those are the main limitations that we saw.
Thank you. So additionally, this was an unblinded trial. Do you think there would have been a way to incorporate blinding, and do you think it may have affected outcomes in any way?
I wrote a little note about that, and it says blinding equals money sign. So yeah, I mean, the whole point of this was to do this cheaply. And Paul Karanicholas helped us respond to one reviewer at one point about this. Blinding is obviously desirable. It certainly makes it feel right and adds to the possibility of eliminating any bias, and bias is real. There was some evidence that blinding does impact trials, and there's some evidence actually that blinding does not have a big impact. And you can look at a number of examples of trials where the same question was answered in a blinded and unblinded fashion, and there were similar outcomes. It depends who's doing an assessment of your outcome, depending on the kind of trial you do. I think it was something we had to accept as a small, I think if there was a tiny difference, people would have harped on that more. I'm not a huge believer, but again, it depends on the kind of trial.
So I'd be interested to hear your thoughts about the SSI rates that were reported in the trial. So in the cefoxitin group, the SSI rate was 32.8%, which seems somewhat high. There's a large national outcomes data pull from Joel Bean that showed that the SSI rate was 20.8. And then when your team was doing the sample size calculations, you calculated a 20.4% SSI rate. Do you think perhaps that people have already adopted broad spectrum antibiotics in their practices, or what do you think the reason for this is?
Yeah, well, obviously the Joel Bean data was what we used. It was interesting to use the same database to develop your hypothesis and your power calculation. So that's the number we assumed. It's really hard to know. I mean, maybe we're doing more neoadjuvant therapy, and patients are sitting with stents for longer, and there's more colonization and risk of infection. Maybe we're doing higher risk patients. Maybe there was more use of broad spectrum antibiotics previously. It's really hard to know. But I think the data is the data. When you have 800 patients randomized, it is what it is. And I think it is more accurate to look within a trial that among the patients you've randomized than it is to compare things that have changed over time. And I guess that's the way I really look at it. And the answer is, of course, I don't really know what happened. We could all sit forever and come up with a million reasons why. But I think the statistical answer is, we all compare things across trials or over time, or, actually Dr. Ahmad was talking about, median survivals across trials and how they can be different based on your denominator, right? And who you selected for the trial. And that's inherently flawed, just like probably the rate of infection in the patients in this trial compared to the prior published trial. And so I don't get too caught up in that. It is what we found. I think sometimes people use those bad comparisons to try to conclude what they want to conclude. Whereas the reality and the beauty of randomized trials is you've done everything possible in the world to eliminate bias within the context of that trial. And we have to get beyond our own biases, and unless it's a completely flawed trial, of course. But I see Paul laughing over there. I stole his discussion there.
That's a great point. Thank you. So we know that you had a follow-up paper with Ryan Ellis looking at biliary culture data, and you showed that two specific organisms were important, and that was Enterococcus and Enterobacter. Do you have any follow-up studies planned? So, we know that previous studies looking at short-term versus long-term antibiotics don't make a difference, and they increase resistant bacteria and C. diff colitis. And we know that adding anaerobic coverage is probably not going to be helpful given your findings. Right. Is there anything further on the pipeline?
I mean, speaking of, a randomized trial and then the definitive answer, this is an example of a hypothesis generating. It was a subset. It was only 8 hospitals, and it was obviously these patients were selected to get their bile cultured based on their institution or perhaps other factors. So it was a hypothesis generating retrospective study in the context of a randomized trial. The most important finding that to me is the bugs that were inherently resistant to cefoxitin, there was no difference in outcome whether you got cefoxitin, but if you gave Zosyn, the difference went away. It was really proof of concept that it was really targeting these bugs. So as you can imagine, there's a million ideas as to what we're going to do. It's not as simple as let's test 1 week versus 24 hours. I don't think that's necessarily the right question. I think actually we're going to try to start to do perhaps smaller single phase hypothesis generating studies to really start to look at really interesting things about specific bugs, wound healing. As you can imagine, there are all kinds of hypotheses about the underlying microbiome, postoperative infections and healing. Very interesting work about Enterococcus and collagenase production in colorectal surgery and colorectal anastomotic healing. We're kind of planning hypothesis generating studies before we jump into some big trial and use this mechanism for other things for the moment.
Is there anything that you wish you had done differently, number one, in this trial? And if you were designing another trial using the NISQUIP platform, anything that you might do differently?
So to be totally honest, Catherine gave me these questions ahead of time, and my answer to that is I don't think I would have done too much differently, and that sounds really bad. I don't know if we just got lucky, or you could answer that. Oh, I would get funding in blind people. I would spend the money or work on NISQUIP to control for more factors than we would have liked to. But the real goal of this, and I remember giving talks 4 or 5 years ago saying this question is not very interesting, but we're really interested in the mechanism. And that is still true. We got lucky. The result of the trial was pure luck. I could tell you we're all geniuses, but we're not. We got lucky. And it was really to establish this mechanism of doing it, and with minimal cost and minimal work for an investigator who wants to participate. And we could talk about that, but like the enthusiasm of folks who do the kind of stuff we do is overwhelming. And to make things easy for them and be part of a trial like this, and all they had to do was give the right antibiotic and everything was done, that was the real goal. So yeah, we could debate all kinds of little things, but I don't think I would change too much. It was a simple question. It was able to be answered by the mechanism, and it established the mechanism. We got lucky that it probably will change standard of care, but that was luck. It was more about the mechanism.
So you addressed that the underlying reasons for the high rates of SSIs were complex. Do you think there may be any potentially non-tested factors here? You had a study at your institution looking at the use of wound protectors, which was able to decrease the rate of SSI by 10%. Would you potentially consider pre-op or perioperative nutrition assessment, early removal of tubes and drains, anything along those lines?
I think all of these studies, wound protectors and closing trays and now antibiotics and all sorts of little things kind of accumulate in their own way. And you can end up with a quality kind of thing where you have a bundle, where you have level 1 evidence for a number of things. You don't really know how they add up to each other. And so I think that's how that will contribute. We did actually, I wouldn't say we controlled for it, but we did record wound protectors. And if you look at that forest plot, it's in there. It seems to be effective in either arm, probably because the dominant problem was, intra-abdominal abscesses and leaks. And wound protectors are not going to impact that. So I don't think so. I'm a purist. I just think about, we randomized everybody. This is what we found. And we could speculate forever about other little things, but the impact was so large that antibiotic has, even if the real difference is smaller, it's got to be real. It may be smaller, but it's got to be real. I'm very convinced that it's real. So I don't overly conclude there's all these other things. And I do believe that you can take sequential level 1 evidence for different things and create a bundle that's very reasonable for an operation like this.
All right. And last question for you. What were some of the biggest logistical challenges in designing and running this trial?
Really funny, and not what I expected. It was by far local IRB approval. By far. I mean, the first year and a half of the study was one center, was us, and we accumulated our 100 patients because we wanted to roll it out slowly and make sure that everything worked. And the least of our troubles was getting people to give the right antibiotic or at the right dosing or data collection. It was by far at the time and frankly, the money it took with every institution to get it approved by their local IRB, which really argues for all kinds of better solutions for that. Central IRBs. And that actually, I guess, maybe to go back to the one thing I might do differently is something like that. To think back on the logistical problem, that was by far the biggest logistic. And you have to realize this is not doing a cancer trial like Dr. Ahmad just talked about. Very different kind of trial. And so I think making that simpler, perhaps with central IRBs, which is becoming a more popular concept that a lot of institutions are buying into, and any way to make that cheaper. I don't have very good opinions about IRBs who charge their own investigators money to do surgery, to do trials, but that's a conversation for a different day.
Thank you very much, Dr. D'Angelica. I think that is all I have. If we want to open it up.
I think I successfully
Okay.
put them all to sleep.
No, that was excellent. Yeah, thanks so much for that discussion, both Dr. Davis and Dr. D'Angelica. That was excellent. So please, if anyone has questions or comments, write them in the chat. I could ask questions for hours if we have to, but nobody wants to hear that. But I will start maybe. Can you comment a little bit more on the difference in fistula rate? Like, do you have obviously it's going to be exploratory or hypothesis generating, but I think that was presumably a surprise, I would imagine, or was it a surprise? And how do you explain that?
We knew that fistulas were a big part of infections, and we also knew that not all infections were related to fistulas. So, and we didn't know how that would shake out. We did not have a specific hypothesis that an antibiotic would change fistula rates. But if I told a surgeon who practiced in the 1980s that bacteria caused ulcers, they would have thrown me out of the room. So sometimes, believing things that seem absolutely crazy is not necessarily a wrong thing. So I think we knew it could be related. And we also knew about Jim Alverdi's data from the University of Chicago. He's a surgeon, a colorectal surgeon who has studied bacteria and colorectal healing. Although I wouldn't, obviously that wasn't the big, it was all based on known resistant to the antibiotics we typically give. I think it does raise an interesting question, Paul, whether secondary endpoints should be considered that are statistically different in a randomized trial should be considered as definitive findings or not. I always like to joke that, you can't say that Columbus didn't discover America because it wasn't a predefined endpoint. He did discover it, albeit probably after the Vikings, but that's a whole other story. Is it a real finding or not? And I actually believe no matter what you find in a randomized trial, it's reasonable to conclude it. And I don't think you are totally limited to your primary endpoint. So I think there is something there.
Great.
Well, thank you for that explanation. One of the questions I have is really related to the platform and the mechanism that was developed in this trial. I think everyone really appreciates the power of running this trial using NSQIP. We've really seen NSQIP kind of evolve over the years from just collecting data on quality, getting more specific related to the collaboratives, and now we've seen a trial being run using it. So I guess my question is, how do we evolve to the next step? So we have NSQIP in a lot of different institutions. People can continue to become parts of the collaborative. How do we use this mechanism to run future trials that can potentially change how we do surgery and how we take care of patients?
So we're going to do another trial. We're going to keep doing liver and pancreas trials sequentially, because I don't know how to give this up. It was too successful. And when I say successful, I don't mean that it was a positive trial. I mean that we accrued quickly and that 98% of people got the assigned treatment. That's the success. So we'll keep doing it. I have spoken to the ACS many times about doing this for other operations, but it's challenging. Again, going back to that original comment I made, that you have to be collecting data on all, if you're going to study and different operations, some general surgery operation or any operation, you have to collect data on all cases. You can't just collect a summary, a sampling of it. So it have to be in the context of specific platforms, and those exist as well. I haven't quite honestly gotten buy-in from the ACS to really develop a group that really runs this across other things, but I think we are perhaps not far from that. They may help financially to start doing this and developing it, and I think it would be in their best interest. I have criticized NSQIP when we were developing this, saying that to spend tens of millions of dollars to do retrospective comparisons is a bit of a sin, and we should do something more definitive like this kind of work. Use the retrospective data to inform trials, and so they didn't love the sin word, but I hopefully inspired them to actually do it. So I think we'll keep using it, and we're not the first. In Europe, they've done it in cardiology trials. They've used registries to do this successfully in Europe as well.
Can you speak a little maybe about the types of trials that you think would be appropriate or wouldn't? Like, were there any concerns with this in terms of ability to monitor the data on a real-time basis, or there's no DSMB in this trial, I don't think, was there? Like,
so there was a DSM, since we were the primary center. Actually, one thing that was not mentioned in the presentation is this trial was stopped early. this was an interim analysis. And there's a whole story behind that, and was done by our local DSMB. So it was not done by a national DSMB. It was, when we run a multi-center trial from our institution, part of the cost we had to imbue was to support our DSMB to follow it. So they stopped it early. So there was a DSMB. What do I think? Well, there's all kinds of really interesting things to ask. Could one thing we could expand this to is like national cancer data, like the NCDB, and ask perioperative questions and their impact on cancer. I actually think perioperative surgery optimization is cancer care. You could limit it to like what we were just talking about. Getting through a Whipple and getting adjuvant therapy is a real challenge. And if you can improve that, if I could make pancreatic fistula infections go away, that number would get much better about who could tolerate adjuvant therapy, and that could have overall survival. So linking with something like the NCDB would be a really interesting thing, but I think that's well into the future. I'm not sure I answered that question completely, but that's the other thing is, from what we did, I think it has to be a perioperative, simple, relatively standard of care, easy to do intervention that is not that susceptible to the issues around blinding. And so, our next trial is going to be based on a single high dose steroid injection at the time of major hepatectomy. And we can go into the data that supports that as a reasonable question to ask. But there are a number of single institution trials that shows that that's powerful and even has an impact on liver regeneration. It's perfect because you can measure liver failure within 30 days. You can, or surrogates for liver failure, and you give a single dose around time. So that's the ideal thing. How we expand other things will be the challenge in the future.
Paul and Matt, can I make a comment and have a question?
Oh yeah, please go ahead, Shisher.
Excellent. So first, I just want to thank everyone. This is phenomenal.
Uh-oh. Did I freeze or did Shisher freeze?
Shisher froze.
Oh.
It's that cheap computer they have at Emory.
It's also strange because he shows as Matthew Paremka, so.
Yeah. Matt, what's going on? He's stolen your identity.
That's true. I didn't even notice that.
He's robbing your bank account right now.
So maybe we'll come back to Shisher if he can fix his connection. Sorry, Shisher.
I'll text
I
him.
wonder, maybe we'll broaden it a little bit in the last 10, 15 minutes here.
Okay.
For
Can you hear me
yeah,
now? Can you hear me?
Yeah, sorry, go ahead. Yeah.
Okay. Sorry about that. So one, I don't know if you heard me, but thank you so much for phenomenal webinar. Just great information, great discussion, and thanks to everyone for doing this. I just wanted one comment to Matt's thing and follow up. I think this platform that Mike led and using ISQUIP has really kind of opened my eyes. And you were talking about where do we go, and I just want to share with you. So we're looking at this mechanism. We're going to run a trial on the NISQUIP platform here at Emory. Totally different question, but just looking at basically post-op Flomax administration for males over the age of 50 who are Flomax naive, looking at urinary retention rates. And that's a question I think that could be very pragmatic, very useful. But we're going to use this NISQUIP platform. And again, using the limitations that we learned about through the antibiotic trial, we're going to limit it to HPB procedures and colorectal resections, because again, those are ones that we do 100% collection on here at Emory at all 3 of our sites. So again, it really does kind of set the stage and extrapolate, because we had submitted a grant trying to get NIH funding for that. Didn't quite get the grant, but it's like, okay, how can we do this? And we'll be able to do this very pragmatically here, just with using our own CRCs. So I think if you start thinking outside the box, there are lots of questions you could use that are actually answerable within that 30-day limitation that NISQUIP uses. So I just wanted to let Mike know, because I think the best form of flat early is emulation. So just so you know, we're going to be running a trial using the same process. And then the question, I guess,
I was just going to say, I think that, for all you quality folks out there, that is real quality. Asking real questions to truly improve things. I don't know how many people know the Hawthorne effect story, but when you pay attention to things and they start to look better, the Hawthorne effect is, and I'll tell it in a second, an engineering place, they improved the lighting, things got better in terms of efficiency, and then they kept changing things and things kept getting better, including putting the lighting back to the way it was in the beginning. So it's not always the fact that this will be real improvement, Shisher. I think that's great.
Yeah, I hope so. We'll see. And I should be able to run. I got 3 fellows going to run it with me, and it'll be a lot of fun. But I think the mechanism is fantastic. And just to add, the antibiotic trial, all they had to do was add 3 data points to the already collected fields on NISQIP. And the same thing for this Foley trial. We're going to basically just add three data points that our CRCs will collect. So you can use that NISQIP platform to really get all the usual stuff that you don't really have we don't need to use funding to get it because we're getting it through NISQIP anyway. So one question I have on antibiotic trial, Mike, as you know, penicillin allergy, which is often documented but relatively rarely real, right? We give cephalosporins all the time to people with pen allergies, but obviously patients in this trial were excluded, and or creatinine clearance less than 40. So in terms of real world application to those patient population undergoing a Whipple, do you think we extrapolate to giving like imipenem perioperatively or some other broad spectrum pen friendly thing, or how do we handle that?
Yeah, 2 comments. Number 1, institute a skin testing penicillin allergy program in your institution, because you're right. Most of these are not allergies. There's something happened when someone was a kid, and I learned this in our own institution. They're starting this because most of these are not real. Secondly, obviously, I can't say anything about something like imipenem because it wasn't tested, but I think it would be completely reasonable to use antibiotics that really target Enterococcus and Enterobacter, because cefoxitin doesn't, and that's what seems to be the mechanism of the impact. And it's a highly involved bug, both in the bile duct and in abscesses cultured after surgery. So yeah, I obviously I can't say it's the right thing to do, but I think it's a totally reasonable extrapolation.
Yeah. Perfect. Again, thank you guys. It's fantastic.
Oh, great. Thanks so much, Shisher, for your leadership as well. I think now we're going to broaden it for the last 10 minutes and maybe try to bring Dr. Ahmed back into the conversation, if we can, to maybe talk a little bit more broadly just about clinical trials and different mechanisms and ways for people to get involved. And I think Dr. Gholami has a question.
Yeah, thank you so much, Paul. I really first of all, really thank you for both of you taking the time and really going over these trials in such details. And we have a lot of trainees and sort of incoming attendings that really strive to really have a clinical trial career. And I would say just being one of them, it is just extremely hard, and just listening to you guys is very admirable. So that's one comment. Could you both sort of allude to, I think we have a lot of trainees again on the call. So what do you think are like maybe the top 3 pointers that you have for people who want to get involved, who want to learn more? How do you situate yourself, like being out of fellowship and trying to, run a trial, like in whatever shape or form that might be, but just sort of some tidbits for people who are on the call?
So thanks, Seth, for a good and important question. So I'll give you my own personal experience, and I think it's you can learn some lessons from what I went through. So when I came out of fellowship, I was excited, enthusiastic. I was going to cure cancer, and I had all these grand plans. And I definitely wanted to do trials as the focus of my research identity, from a way for me to make an impact in the field. And I wanted to incorporate translational questions from all the preclinical laboratory experience that I had during residency and fellowship. And so I came to Cincinnati and I wrote 1 and 2 trials here. And the lesson I learned was that it was really hard to get studies done, at an academic institution, maybe that wasn't Memorial or MD Anderson, where you had this huge patient volume. And both those studies accrued some patients, but it never got off the ground and completed completely. So, my mentor at that time was Andy Lowy, and he said, well, one way you could do this is through the cooperative group mechanism. Why don't you come to the SWOG meetings and get involved there? And, I went there, and it was like a fish out of water. It was like everyone was a medical oncologist. There weren't that many surgeons. I kind of felt like, do I belong here? And the lesson number 1 was, you need to be present to be involved. So you need to go to these meetings, you need to listen, ask questions, talk to people, get to know people. The thing you'll learn in the cooperative group is that people value the input of surgeons. They want to work with you. They want to incorporate you into ideas and studies. But you can't just go and expect like a trial to fall in your lap. You have to go there and be patient and work on little projects, and eventually you get, to be a PI on a study. And so expand, your horizon, work outside your institution, get to know people around the country through these mechanisms, the cooperative group mechanisms, and get the training you need. Most of these cooperative groups will have clinical trial courses, young investigator courses. You can get it through the American College of Surgeons. You can get it through ASCO. There are many ways to get trained to be a trialist. In the cooperative group, if you do a young investigators course, you get certified to be a PI in a study, and you work on that. And Sep, perhaps you can talk about your experience in SWOG as someone who's really an emerging star in that cooperative group. And so, get to know people around the country, expand your horizon, be present, be patient. This is not like doing basic science research where you come up with a question, you go in and do some Westerns and Northerns and PCRs, and you have some bands to look at. This takes years and years of patience. There'll be lots of, a lot of disappointments, but eventually something hits. What I always tell people is that as a research scientist, whether you're doing basic science or clinical trials, you're working at a population level where when you finally make progress, you're going to help thousands of patients at once. And so it's worth the time, it's worth the effort to put in, to get the training, to get involved and really make an impact at a population level. I'll let Mike comment.
Yeah, of course, I agree with all that. It is interesting. More and more of our fellows come through my office and say they want to do clinical trials. And I say, well, I've done a bunch. It takes many years to go from idea to writing a paper. What are you going to do in between those years? So it's as a research career, you have to think about what else you're going to do in between, and how you do trials and how you learn. I think Dr. Ahmad just told you there's lots of ways to learn, and I think he's actually probably more than anyone introduced me to the cooperative groups, because my experience was different. Yes, I worked at one of these high volume centers, and so I was able to do single institution trials on regional chemotherapy for colorectal liver metastases. And that was amazing. Very few people have that resource. So I think it's a matter of taking advantage of the resources you have. I will also tell you that single institution trials are not as impactful as you think they're going to be. And at least I have learned that here. There are plenty of trials we've done here that have not had great impact, probably because, as we're criticized, memorial is not the real world. There's a lot of truth to that. And so I think getting involved in cooperative groups probably has a bigger impact. My advice to the fellows who really want to get involved is exactly what Dr. Ahmad said. I think if you work in an institution, you can do trials there, most of which will be hypothesis generating for a cooperative group. That's great, but go show up. I've been to a couple of meetings with the cooperative groups over the years, and I can tell you, as a surgeon in the room, I often felt everybody in the room sort of turning to the surgeons to answer certain questions that a lot of the people in the room didn't have. So I think it would be great. It's great for young surgeons to get involved, but don't expect much to happen for a long time. Patience is probably key. And if you want to have an academic impact, I think you need another plan to do in parallel with that, whether that's little trials in your own institution. And I think you can do fascinating single arm hypothesis generating trials within an institution, especially with good, interesting biological correlates. You don't have to be super high volume to do those, whatever your interest is. So that's my take on it.
That's really helpful. I think just for those who are on the call, just personally, I think the one thing I would also add is just find a mentor. I think obviously, I learned from Mike being like sort of, following an example and having trained under him and watching him. But then, I was at an institution that didn't have all the resources, and I did actually step up and, went to a SWOG meeting before I even actually met Dr. Ahmad, which was really interesting. I actually went to the president of SWOG, having just watched a lecture and was fascinated by it. And I literally went up and said, I'm a surgeon. I'm being told I cannot be a clinical trialist. How do I get involved? And I think we underestimate how people can be really like sort of supportive. I immediately got a letter and like an email to Dr. Ahmad saying, this person, this young female will join your group. And he actually even funded my travel to SWOG. So I think if people want us to be involved, and that's important for people to hear, because often enough we hear that, you can't be as a surgeon, really involved, and, especially in cancer care, the med onc rules the field, and that's not really true. So I think we're coming to an end. It's 6:29. If there's any final questions or comments, otherwise, I really want to just thank our amazing panelists, our presenters, and Paul and Matthew, like really for everyone. And we'll have one more final session. And for everyone who's on this call, the webinars are recorded. Every session, you can go back and listen even to the ones from last year. And we do still offer a certificate if you take your exam. So don't forget, and it's just some learning. So that's just your step number one on getting involved and, asking questions. So thank you again for everyone who joined today.
Thanks, everyone.
Thank you. It's an honor.
Take care.